This is a University of Kentucky Anesthesiology Basic Keyword Review entitled Traumatic Complications of Anesthesia Procedures and Positioning. These are the keywords from the current American Board of Anesthesiology content outline that I intend to cover during this presentation. We'll start with a discussion of airway trauma. Minor complications of airway management, such as sore throat, are common, while serious injuries are rare. Airway trauma can include nasal bleeding and traumatic injury, dental injuries, soft tissue trauma, nerve injuries, and laryngeal injuries. According to the American Society of Anesthesiologists closed claims analysis, 17% of claims were due to respiratory events, and 7% of reported claims were due to airway injury, according to UpToDate. Markers of a potentially difficult airway make the patient at a higher risk of airway injury, obviously. The biggest contributing factors include difficult intubation and/or multiple attempts at intubations, having an emergency intubation, or an intubation outside of the operating room. Supraglottic airways are also associated with traumatic injuries. I'd like to talk about prevention of injury in all these different categories described. We'll start with nasal intubations and airway injuries. Epistaxis during nasal intubation can be devastating, and it can occur during intubation or after extubation. How to prevent it? The best course is by applying topical vasoconstrictors, such as oxymetazoline, and pre-softening of your endotracheal tube, and using smaller sizes when indicated. However, what do you do if it still occurs? A review by authors Hall and Schutt recommended that epistaxis during nasotracheal intubation be managed as follows. If bleeding occurs during the tube insertion, intubation should be completed as rapidly as possible, with the endotracheal tube itself acting to tamponade the bleeding. And if tracheal intubation cannot be completed at the time and there is active bleeding during the attempted intubation, the endotracheal tube may be withdrawn and repositioned with the inflated cuff within the postnasal space to prevent blood passing into the oropharynx and act simultaneously as a nasopharyngeal airway. You could then attempt oral intubation. Post-extubation, epistaxis is potentially more dangerous as the bleeding clouds the views of the airways. 2 case reports from 2019 describe successfully using a fully balloon catheter inserted into the nair and then inflated to rest against the postnasal space and successfully stopped hemorrhage. Dental injuries are very common. They are in fact the most common claim after anesthesia, upper incisors being the most vulnerable. The incidence varies widely in the literature depending on how it is defined. Risk factors for dental injury during general anesthesia include difficult intubation and pre-existing poor dentition or dental reconstruction, and a comprehensive preoperative evaluation should include dental baseline assessment and informed consent of the risks. Some damage may be unavoidable. Technique is the biggest modifiable factor that lowers the risk of dental damage. Any teeth dislodged during laryngoscopy should be retrieved and retained in saline. Dislodged teeth are at risk of being lost in the oral cavity, trachea, or esophagus during airway management. Dental consultation should be obtained post-operatively for any dental injury, especially if the tooth was dislodged. Video laryngoscopy has not been shown to be conclusively superior to direct laryngoscopy in terms of reducing the propensity for dental damage. Dental guards or protective devices do not conclusively protect the teeth. Soft bite blocks, when a patient is positioned prone or using motor evoked potentials or electroconvulsive therapy treatment, have been shown to prevent some injuries. Injuries to the soft tissues or lower airways can also occur. Patients with coagulopathies, oropharyngeal edema, neck radiation, and history of difficult intubation are at higher risk of significant injury to the soft tissues along the airway. The literature comparing laryngeal and airway trauma with the use of video-assisted laryngoscopy versus direct laryngoscopy is mixed. During video-assisted laryngoscopy, injury can occur when inserting the video laryngoscope blindly or when passing the ET tube blindly between the back of the pharynx, the point at which the operator loses direct sight of the tip of the endotracheal tube, and when it is visible with the camera at the laryngeal inlet. Injuries have been reported to the tonsils and the palate due to blind endotracheal tube placement. Injury may be minimized by inserting both the video laryngoscope and the endotracheal tube into the mouth under direct vision rather than looking at the monitor until they pass beyond the soft palate. Injuries or edema of the uvula, epiglottis, tongue, and pharynx have been rarely reported with the use of supraglottic airways. The risk of injury may be reduced by avoiding overinflation of the oropharyngeal cuff and troubleshooting or repositioning a poorly functioning supraglottic airway. Soft tissue injury as a result of ventilation by face mask is rare and usually minor, and may include jaw soreness or irritation of the skin or lip under the mask itself. Corneal abrasion has also been reported and can be avoided by choosing the correctly sized face mask and by securing the eyelids closed with tape or occlusive dressing prior to application of the mask. Most patients with laryngeal injury manifest as hoarseness or dysphonia immediately following extubation. Other injuries, such as bilateral vocal cord paralysis, severe edema, or severe laryngeal tracheal stenosis, can also be associated with extubation failure, presenting with acute stridor or respiratory failure after extubation. Stenosis of the larynx and/or trachea is a late complication of endotracheal tube placement that takes place weeks to months, developing after the initial intubation. The risk of developing stenosis is increased in those with prolonged intubation, usually more than 7 days, and is rare in those intubated for short periods, less than 3 days. The incidence is unknown, but reports range from 1 to 21%. Now we'll switch to talking about trauma to the eyes and postoperative visual loss. It's being classified into 4 categories, corneal abrasions being by far and away the most common, postoperative ischemic optic neuropathy, cerebral visual loss, and central retinal artery occlusion, abbreviated as CREO. This information is given from UpToDate. Corneal abrasions are the most common injuries to the eyes from anesthetic care. Single-center studies have found an incidence ranging from 0.09 per 1,000 to 1 events per 1,000 under general anesthetics. These can occur from corneal drying and loss of tear production under general anesthesia, or from direct trauma to the eyes that are unprotected. In 3 single institution database studies and 1 study using a national database, the risk of corneal abrasion was higher in patients who underwent surgery in non-supine positions, including lateral, prone, and steep Trendelenburg. A presumptive diagnosis of corneal abrasion is often made postoperatively in a patient with eye pain, foreign body sensation, and photophobia. Administration of topical antibiotics and for large abrasions, cycloplegics, have been the mainstay of therapy for decades, along with daily follow-up until the eye is healed. Patching was previously routine but is no longer recommended for most patients. You should rule out the presence of a foreign body in the eye and refer to ophthalmology when appropriate. Eyes can also be painful from acute closed-angle glaucoma and retrobulbar hemorrhage, which are ocular emergencies and should be ruled out in the presence of eye pain. Now we'll talk about ischemic optic neuropathy. Ischemic optic neuropathy, abbreviated ION, is the most common cause of permanent postoperative visual loss in adults after non-ocular surgery. It is more common after cardiac, spine, and orthopedic procedures compared with abdominal surgery, and it has been reported after bilateral radical neck procedures and in cases performed in the steep Trendelenburg position, such as laparoscopic, gynecologic, and urologic procedures. The incidence is estimated at 0.6 per 10,000 from 2010 to 2012. Retrospective data from 2009 cite the highest risk procedures to be spinal fusion, an estimated risk of 3.09 per 10,000, with higher estimates for posterior versus anterior fusions, and cardiac surgery, with an estimated incidence of 8.06 per 10,000, which is quite high. The anterior versus posterior distinction of ischemic optic neuropathy derives from the dual blood supply to the optic nerve, which we'll cover in more detail on the next slide. The optic nerve has branches of blood supply off of the ophthalmic artery, which more proximately branches into the central retinal artery for central blood supply, and peripheral supply from the posterior ciliary arteries, which confluence in the circle of Zinnhaller at the optic nerve head. The zones of ischemia are illustrated below, thus anterior versus posterior. The key to ophthalmologic differentiation is on fundoscopy. Anterior ischemic optic neuropathy will show abnormalities, for example, disc at risk, while posterior ischemic optic neuropathy will initially show a normal fundoscopic exam for the first days to weeks due to its more retrobulbar ischemia. Ischemic optic neuropathy is not exclusively a surgical problem, and there exists both arteritic and non-arteritic forms of ION. The arteritic forms are rare and associated with giant cell or temporal cell arteritis and are medical emergencies requiring steroid treatment. The non-arteritic forms are from non-inflammatory causes and include perioperative ischemic optic neuropathy. Most patients who develop non-arteritic anterior or posterior ION have underlying vascular diseases such as hypertension, diabetes, or hypercholesterolemia. Those are non-modifiable risk factors. There is no specific treatment for non-arteritic ION, although some case reports have shown reversibility with treatment of blood pressure and anemia. Patients should be assumed to be at risk of permanent visual loss if ION is diagnosed. I'd like to focus on the surgical risk factors for ischemic optic neuropathy, as it is a known perioperative condition. And in 2019, the American Society of Anesthesiologists published the Associated Practice Advisory on the slide for perioperative visual loss, and I would refer you to this document for more complete detailed information. From this practice advisory, we have several recommendations. These include the following: maintaining arterial blood pressures at higher levels in hypertensive patients to maintain end organ perfusion, a careful assessment of the need for deliberate hypotension and the risks, because hypotension is a major risk factor for ischemic optic neuropathy, monitoring for and promptly correcting severe anemia from blood loss, maintaining the head and neck in a neutral forward position in the prone position, and maintain the head slightly higher than the body. Avoid direct pressure on the globes of the eye and check the eyes periodically during surgeries. Their final recommendation is to stage the procedures if they're anticipated to be of significant length, as prolonged procedures, especially in the prone position, are known to be a risk factor. Postoperatively, if there is a concern for visual loss, a prompt ophthalmologic consultation is advised, with concurrent optimization of hemoglobin and hematocrit, blood pressure, and arterial oxygenation. In the past, higher associations with ION have been correlated with the male sex, obesity, and use of the Wilson frame, which is largely unused in modern surgical practice. I'd like to talk now about the concept of cerebral or cortical visual loss. Cerebral or cortical visual loss is one of the more common types of postoperative visual losses. A study of over 5.6 million surgical procedures using the nationwide inpatient sample found that post-op visual loss due to cerebral visual loss occurred in 0.38 per 10,000 discharges after cardiac, spinal fusion, non-fusion orthopedic, and abdominal surgeries. Post-op cerebral visual loss is more common in patients less than 18 years of age, occurring in 4.3 per 10,000 cases. After adjusting for other risk factors, the risk of cerebral visual impairment in patients less than 18 years old was increased 64-fold over that of patients greater than 18 years old. This visual loss is usually caused by emboli, resulting in infarction of the posterior cerebral artery territories, or less commonly by profound hypotension with watershed infarcts in the parietal occipital regions. Embolism and/or hemodynamic instability can occur during cardiac, spinal fusion, and non-fusion orthopedic surgeries. Note that this clinically is a painless condition with preserved pupillary light reflexes and normal fundoscopic findings on the initial exam. The other common cause of visual loss is central retinal artery occlusion, abbreviated CRAO or CRAO. Central retinal artery occlusion is the most commonly reported retinal cause of visual loss after non-ocular surgery. CRAO has occurred after head and neck procedures, cardiac surgery, and prone spine cases. The etiology of CRAO is presumed to be embolic in the cardiac and head and neck surgeries. However, CRAO after prone spine surgery is frequently associated with periorbital trauma, suggesting that in those cases the etiology may be sustained globe compression. A rare cause of CRAO relates to the use of nitrous oxide in patients who have had recent placement of gas expansion bubbles during vitrectomy for retinal detachment surgery. These gas bubbles may remain in the eye for 10 to 14 days when sulfur hexafluoride is injected, and up to 55 to 65 days when perfluorocarbons are injected. Because nitrous oxide readily diffuses into these bubbles, the bubble may increase in size and raise the intraocular pressure to levels that occlude central retinal artery flow. Permanent damage to the retina and optic nerve may occur with nitrous oxide administration for more than 1 to 2 hours. Postoperative CRAO is almost always unilateral, and patients typically complain of severe loss of vision in one eye immediately after awakening from anesthesia. So, a summary of a differential diagnoses for postoperative visual loss. Does a patient have pain or not? If they have pain in the eye, corneal abrasion or foreign body or trauma to the eye or CRAO should be top in your differentials. If they do not have pain, ischemic optic neuropathy or cortical blindness should be in your differential. The next steps include consulting ophthalmology and doing a good fundoscopy exam. Patient cooperation and level of alertness with an exam may be a confounder to your diagnoses. So now we're switching gears to item number 4 on the ABA content outline, vascular procedural complications. We're going to start by talking about procedural complications of peripheral IVs, which is the most common vascular procedure we do in anesthesiology. Among the more common complications are phlebitis, extravasation of IV fluids, bruising, and hematoma formation. Thrombophlebitis occurs in up to 15% of those with peripheral venous catheters, so this is quite common. This risk can be reduced by avoiding lower extremity IV placement, minimizing catheter movement, placing the smallest suitable catheter size, and removing the catheter as soon as possible. Catheters placed in emergency circumstances are more prone to complications. For catheters that may need to be in place for longer periods, splinting the proximate joint and thereby preventing or minimizing catheter motion may reduce the risk for thrombophlebitis. Peripheral venous catheters are thought to be rare causes of bloodstream infections. The risk of an infection from a peripheral IV catheter and the practice of using a fixed schedule, or for example, 3 days to replace catheters, is not supported by the data. The data simply do not support arbitrary replacement of peripheral IVs on a fixed schedule to reduce this risk. Catheter shearing is a risk with retractions back over needles and wires. Fragments could potentially obstruct or embolize inside the patient. So we'll talk about procedural complications of arterial lines. Complications of indwelling arterial catheters include bruising, pain, swelling, hematomas or bleeding at the insertion site, which can be profound, damage to adjacent structures, local or systemic infection, and iatrogenic blood loss due to sampling. In addition, specific vascular complications include vasospasm, thromboembolism, dissection, pseudoaneurysm, or arteriovenous fistula formation. These vascular complications may cause local or distal ischemia that can progress to necrosis in rare instances. Vasospasm is a common complication following arterial catheterization, occurring in 57% of patients in one study, and is typically an initial sign in arteries that develop thrombosis. Risk factors for thrombosis include an increased duration of catheterization, for example, longer than 72 hours, a larger catheter in a smaller blood vessel, and low flow states such as low cardiac output or other sources of shock. peripheral arterial disease, or vasospastic disorders like Raynaud phenomenon. We do not routinely use heparin or sodium citrate to maintain patency of intra-arterial catheters, but rather use saline for flushing and maintenance of catheter patency. Air bubbles in the flush solution of an arterial catheter monitoring system can embolize antegrade or retrograde and may cause ischemic damage to the brain, spinal cord, heart, or skin. In a primate model, just 2 milliliters of air injected into the radial artery with the standardized pressurized infusion bag resulted in clinically significant cerebral air emboli. Such emboli are more likely in patients who are small in size or are sitting upright. Although many sites share the same possible complications, such as bleeding, the frequency of these complications varies among different insertion sites. As examples, the most common complications associated with radial artery catheterization are occlusion from 2 to 35% and hematoma up to 15%. Permanent injury rarely results from either complication. A common complication associated with femoral artery catheterization is hematomas in 6%, which can be large and difficult to detect if extension to the retroperitoneum occurs. So I'd like to talk about central venous catheters and complications. There are complications that are both immediate and delayed, and complications that are common to all sites and specific to certain sites. A nice list or summary is provided here from UpToDate. Common to all sites include bleeding, infection, catheter malfunction, migration, perforation or injury, but certain complications are specific to certain sites, such as thoracic duct injury and pneumothorax only with subclavian or internal jugular approaches. The incidences of different complications vary widely in the literature. A later study examining complications of central venous catheters by insertion sites noted that 2.1% of patients had mechanical complications during insertion, 0.5 to 1.4% experienced bloodstream infections, and 0.5 to 1.4% developed deep vein thrombosis attributable to the central venous catheter. The rate of mechanical complications is significantly decreased with the use of dynamic ultrasound-guided venous access. This is another table provided by UpToDate comparing specific sites and approaches in terms of advantages and disadvantages for central line catheterization. Mechanical complications are more common after attempted insertion in the subclavian vein compared with the internal jugular approach and are least common for the femoral vein. However, the subclavian approach is still associated with fewer bloodstream infections and symptomatic thrombosis. Nevertheless, to avoid future complications such as central vein stenosis, the subclavian site should be avoided when placing central catheters in those with chronic kidney disease. The femoral vein has the highest risk for infections with skin flora and difficulty maintaining sterility or keeping moisture off the site in the long term, but it is best or most convenient in emergency situations or when doing CPR. Finally, we'll talk about complications associated with pulmonary artery catheterization. Common complications of insertion include the occurrence of atrial and/or ventricular arrhythmias as you enter the heart with the catheter. Less commonly, catheter misplacement or knotting can occur. Perforation of a cardiac chamber and rupture of a cardiac valve or the pulmonary artery are rare complications that can be catastrophic. Many of these complications can be minimized but not eliminated by paying careful attention to the pressure waveforms during insertion and by ensuring that the balloon at the tip of the catheter is fully inflated, so that the catheter tip does not protrude beyond the balloon, as shown in the diagram. Pulmonary artery perforation is the most feared and deadly complication, with a mortality from 30 to 70%. We're moving now to item number 5 on the ABA keyword list, which is neurological complications, and starting with neurological perioperative injuries. I'm going to talk a little bit about tourniquet injuries, direct pressure injuries, and peripheral neuropathies. Tourniquets have been used for centuries to occlude arterial flow distal to the device to control extremity bleeding and provide a clearer surgical field, often in orthopedic surgeries. Tourniquets can result in temporary or permanent injury to the underlying nerves, muscles, blood vessels, and soft tissues. Advances in safety, accuracy, and reliability of surgical tourniquet systems have reduced nerve-related injuries by reducing the pressure levels and pressure gradients, but that may have resulted in reduced awareness of potential injury mechanisms. Damage to nerve fibers resulting from a compression tourniquet was the direct result of the applied pressure and not a consequence of secondary ischemia, and that the pressure gradient was higher near the edges rather than in the middle of a tourniquet. Subsequent studies have shown that ischemia is also of relevance, particularly at the distal cuff edge and below. In patients with tourniquet-induced paralysis, there is focal conduction delay at the level of the tourniquet. Tourniquet compression nerve injuries are typically transient, and resulting symptomatology is usually mild to moderate. However, when the applied pressure gradient is high, there is a risk of directly injuring the axon of the nerve. This results in the same pathophysiology as direct compression injuries. Further information on peripheral neuropathies is summarized by UpToDate. I would encourage you to see this practice advisory listed here for prevention of perioperative peripheral neuropathies, published in 2018 by the American Society of Anesthesiologists for more complete information. Perioperative peripheral nerve injury can result in temporary or permanent sensory or motor deficits, paresthesias, or pain, and in some cases, these injuries are related to patient positioning. Nerve injury after anesthesia is a rare event, and the true incidence is unknown. Some estimates are 0.03%. The mechanisms for perioperative nerve injury are incompletely understood and may involve local mechanical insult related to positioning, such as compression or stretch, ischemia, and/or inflammation. Nerve injury may also be related to pre-existing patient factors, such as pre-existing subclinical neuropathy, diabetes, hypertension, or body habitus, or as yet undetermined factors. Some nerves are at particular risk for position-related injury, either because of a superficial course that is vulnerable to compression, for example, the peroneal nerve at the fibular head or the ulnar nerve in the ulnar groove at the elbow, or because of potential stretch, for example, a brachial plexus stretch with neck rotation. Perioperative peripheral nerve injury is difficult to predict and difficult to prevent. There is no universally effective treatment. Now we'll talk about surgical positioning and associated neurological injuries. I will cover the positions supine, lithotomy, lateral decubitus, prone, and sitting. Nerve injuries associated with supine positioning include brachial plexus. The arm should be positioned to minimize the chance of brachial plexus and ulnar nerve injuries, recognizing that the majority of perioperative nerve injuries occur despite what is considered optimal positioning. Neutrally positioned arms with padding over the olecranon epicondyles and radial head is considered optimal. In lithotomy, several types of lower extremity nerve injuries may be more common, and this can include the common peroneal or fibular nerve as it courses over the fibular head, the saphenous nerve, the lateral femoral cutaneous and obturator nerves, and the sciatic nerve. In an observational study of patients positioned in lithotomy, 1.5% of patients experienced transient sensory lower extremity neuropathy. Note that hand and finger injuries can happen in lithotomy with the arms tucked and the moving of the footboards. Amputation of the fingers have actually been reported. In the lateral decubitus position, we typically worry about the brachial plexus. The brachial plexus is at risk for injury if a chest pad or roll is not properly placed. Although this device is often called the axillary roll, it should not be placed in the axilla. Rather, the chest should be supported caudal to the axilla to free the axillary structures from compression. Nerve injuries associated with the prone position include the upper extremities and the cervical spine. The upper extremities are at risk of peripheral nerve injuries. They can be placed at the sides or extended along the head on the arm boards. If the arms are positioned with the hands up, the arms should not be overextended to avoid stretching or compressing the neurovascular bundles in the axilla. The cervical spine should be maintained in neutrality with the rest of the spine and avoiding too much flexion or extension at the C-spine. In the sitting position, the brachial plexus is also at risk for stretch if the arms are inadequately supported. The ulnar nerve may be compressed at the elbow and should be padded. The hips should also be flexed no more than 90 degrees, and the knees should be slightly flexed to prevent stretch injury of the sciatic nerve in the sitting position. Thin patients may benefit from extra seat padding as they may be at higher risk of sciatic nerve compression where it exits the pelvis. Neck flexion that may be used during craniotomy has been implicated in rare cases of quadriplegia. Pre-existing cervical spine stenosis may place patients at higher risk of such injuries. This slide is just a cartoon graphic showing you some of the nerves at risk in the lithotomy position. As a visual learner, I like to see this. We're going to transition to our final topic, which includes perioperative burn injuries. A fire in the operating room is a relatively rare event. However, when a fire does occur, the medical outcomes may be catastrophic if the patient is injured, with severe legal and economic consequences for the surgical team and the facility. Most operating room fires are preventable with communication, appropriate education, and risk management. Reports of the occurrence of operating room fires have ranged from 217 to 650 events each year in the United States. Patient injuries after an OR fire are often severe. For example, painful and disfiguring burns to the face and neck or severe airway injury with tracheostomy and permanent lung damage. Typically, a surviving patient must undergo several surgeries to treat acute burn injuries and revise scar tissue, causing recurring anxiety, post-traumatic stress, and economic burden. The combination of an oxidizer, for example, oxygen, nitrous oxide, a fuel, for example, alcohol-based PrEP solutions, surgical towels and drapes, and an ignition source, for example, an electrosurgical unit or a laser, in a closed environment can result in the eruption of flames. This is known as a fire triad. Strategies to prevent and extinguish fires are based on separating and/or controlling these three elements of the fire triad. Oxidizers are not fuels and are not consumed in a fire, but act to accelerate the burning process. An ignition source, such as heat, is the remaining element in the fire triad. Although it is possible for flames to erupt when an ignition source comes into contact with the fuel and room air, the flame will be more intense and severe in an environment with an increased concentration of oxygen. Monopolar electrocautery is highest risk and most commonly used. The use of bipolar reduces the risk of electrical arcing or sparks, but does not eliminate the risk. When you start to think about sources of fuel for a fire in the operating room, you realize there are many. And this table from up to date delineates fuel sources that are commonly found in the operating room. You can see this includes PrEP agents, dressings, drapes and covers, different kinds of ointments, the patient themselves, anesthesia equipment, and multiple other equipments that could rapidly propagate a fire. It is important to identify high-risk situations and procedures such as head and neck surgeries with higher risks of airway fires specifically. So how do you prevent a perioperative burn injury? You must assess the fire risk of procedures routinely during timeouts and address the emergency plans for fire during timeouts. And you must work to reduce the risk during higher risk procedures such as head and neck and open airway surgeries. You have to think about your management of open oxygen delivery systems. For procedures at or above the xiphoid, avoid open oxygen delivery, for example, via a nasal cannula or face mask whenever possible. Many healthy patients can tolerate sedation without oxygen supplementation during monitored anesthesia care. For patients who require oxygen supplementation to avoid hypoxia, use an oxygen blender or an adapter to the common gas outlet of the anesthesia workstation to deliver an oxygen concentration less than 30% via an open system. If a patient requires high oxygen concentration to maintain an adequate saturation, a closed system is advised. High-flow nasal oxygen use for a patient undergoing MAC anesthesia presents an extreme risk for operating fire, and you should probably rethink your anesthetic plan. Remember that communication is key. Before activation of any ignition source in a patient receiving oxygen via an open oxygen delivery system, the surgeon must notify the anesthesiologist to ensure that the oxygen concentration has been reduced to less than 30% or room air. Generally, 3 to 5 minutes is required to allow dissipation of the oxygen concentration on the surgical field. Airway surgical procedures have the highest airway fire risk score on assessments such as the Silverstein Fire Risk Assessment tool. Prevention, in addition to the above measures, includes using a fire-resistant endotracheal tube when available. For procedures with planned laser use inside or near the airway in an intubated patient, you can use a cuffed laser-resistant endotracheal tube regardless of the oxygen concentration. Key points include the following. The selected endotracheal tube must be resistant to the particular laser that will be used, and there are manufacturer guidelines for this. You can fill the cuff of the endotracheal tube with saline colored with an indicator dye such as methylene blue, which acts as a marker if the cuff happens to be perforated by the laser. Then you would know that you must immediately turn off your oxidizer. The earliest warnings of a fire include smelling smoke, hearing a pop, or seeing a flash. The surgical procedure should be halted immediately or as soon as it is safe to do so, while the possibility of a fire is investigated. If it is confirmed, all efforts are directed towards stopping the burning process and removing the fire source. If there is a fire on the patient, you must stop the flow of all anesthetic gases, provide water or saline onto the burning site, remove the drapes and other fuel sources, and grab a fire extinguisher, usually carbon dioxide base, and activate the RACE protocol. If there is fire in the airway, you must remove the endotracheal tube immediately and simultaneously stop the flow of all airway gases. The precise sequence of these two tasks is not as important as accomplishing both immediately. You should pour water or saline into the patient's airway to extinguish any residual burning materials after the endotracheal tube is removed and all gases have been shut off: oxygen, nitrous oxide, and or medical air. You must reestablish ventilation as soon as possible, preferably without the use of either oxygen or nitrous after the fire has been extinguished, and assess the upper and lower airway as soon as possible with bronchoscopic visualization. In summary, anesthesiologists play a large part in keeping patients safe in the operating rooms. Careful technique with our procedures is one of the best preventative measures. Risk assessment and communication of risk, working as a team, and following protocols are equally important. I hope you found this review helpful for your studies.